Hello. Check, check, check.
Hello, testing, check, test. Hello, testing, check, test. Hello, testing, check, test.
Very good evening and a very hearty welcome to one and all. I am Sirish Samak, Senior Vice President Microlabs. On behalf of CCAI and Micro Knowledge Academy, I take pleasure in welcoming each and every one of you across 30 locations of the country. This perhaps is one of the biggest hybrid CMEs in the recent times, and I would personally like to thank Dr. Sadanand Shetty and Dr. VT Shah of CCI for all the cooperation help they have given us for arranging these programs. And this program has been live streamed across 30 locations, like I said, across the country. And what's more, sir, there are close to 170 faculty in terms of moderators and the panel members across the country, with close to 2,000 delegates watching this program. And the whole thing is live streamed from Mumbai. I think that's one great attempt what we have tried, and I'm absolutely happy to share with you that it's coming out very well. So again, on behalf of CCA and Micro Knowledge Academy, we thank each faculty for gracefully accepting our invitation to be part of this so-called sort of a historic event from Microlabs. And we at Microlabs are very, very happy to inform you that we are stepping into the 50th year of our existence in the Indian pharma industry. And very, very few companies have entered this kind of a landmark. And probably it's a lovely and a perfect occasion for us to partner with CCI for such an event. In our journey in the last 50 years, Microlabs has gained the trust of the medical fraternity. And we not only have operations in India, but also have our wings spread across 60 countries globally. We not only have an excellent basket of products, but we are also happy to be associated with the medical fraternity with our commitment to support the dissemination of knowledge across the specialties. We operate in close to 14 specialties, and our presence is made quite aggressively across. And we are proud and thankful to the medical fraternity for establishing our brands like Dolo, Amlong, Arbital, which are almost household names across the country. And for all of us at Microlabs, today is a very important day as we are announcing the launch of a product which is first time in India, a combination of one of the most accepted beta blockers and one of the most trusted ARVs. So probably it's a proud occasion for all of us. Probably we are very sure that this product would help you in treating your patients better. Today's event would have two talks from the eminent speakers. Eminent cardiologists, senior interventional cardiologists from across the country, Dr. C.K. Ponde from Mumbai and Dr. G.S. Wander from Ludhiana. And that would be followed by panel discussions and question and answer sessions in the respective locations. I would not take much of your time. I would want to welcome Dr. VT Shah onto the dais to chair today's session. Dr. VT Shah needs no introduction. He's been one of the senior interventional cardiologists of Mumbai. He's been practicing for over 30 years. He's been trained in Germany in this interventional cardiology and has been a senior consultant interventional cardiologist in Mumbai. Sir, I request you to kindly take over the session and take over the proceedings. Thank you very much.
Thanks, Mr. Samak. First of all, I would like to congratulate you and Microlabs for this 50th year, and I think they deserve a round of applause from all of us. Secondly, on behalf of Classic Cardio Academy International, myself and Dr. Sadanand Shetty, we definitely acknowledge the warm welcome they have given to us to see that we do some academic programs, especially through their Micro Knowledge Academy, which has been also another academic funded by them to spread knowledge in different branches of medicine. So without delay, when their first molecule was being introduced, I told him, why not take this opportunity and do such a program, because we had been doing this during COVID times. But that was only virtual. So we thought this time, why not do it a hybrid program? And he did all the groundwork and came with all this, and we suggested it. So today, I think it is fruitful that by 2 lectures given and then having local panel discussions, we will be discussing this topic, especially on the new product, the fixed dose combination that they are coming around with, bisoprolol and telmisartan. So all of us have been using telmisartan with beta blockers other than bisoprolol, and today we are going to see how this molecule is going to be different and will have advantages. And for that we have none other than a very well-known academician in the field of cardiology, that is Dr. C.K. Ponde. Fortunately, I am from the same institute where he was trained, so if at all you see some glimpses of Ponde in me, it is all because of him. So friends, Ponde has been an excellent academician right from his student days. He has been gold medalist, he has been trained in Australia, he has received several awards and has published many papers. Currently is head of department at Hinduja Hospital in the Department of Cardiology, and does excellent research work there with all the infrastructure which he has and the thoughts which he has, and spreads this knowledge across India. So with these few words, I request Dr. Ponde to please take the dais and speak on this topic. Thank you very much.
Thanks, VT, for that very lovely introduction. I think very few of you in the crowd would know that VT has been my teacher in the past in Sholapur. So when I was a medical registrar, I was a medical houseman, he was our senior most registrar. So you can imagine. So thanks to Microlabs for inviting me here. It's a sort of a difficult topic, or not difficult topic, I would say. I don't usually talk on molecules. I usually talk on concepts, themes, or policy changing decisions or something like that. And I love talking on those. But this is one occasion where I will be talking on molecule. But of course, beta blockers, as you all know, is a concept. Which evolved. Slides are not moving. So this is Sir James Black. You must have seen him several times in several lectures. The man who invented the first beta blocker in the world and got a Nobel Prize for the same. So if you go into the history, in 1960, Sir James Black, a Scottish pharmacologist, he invented the beta blockers for treatment of angina. The first beta blocker that he invented was pronethelol. Pronethelol was a long-acting beta blocker released in 1963. And was marketed only for life-threatening conditions because of its multiple side effects. So non-cardioselective beta blocker, extremely long-acting, ultra-long-acting. And then came propranolol, called Inderal, which quickly became the best-selling drug. As you all know, in our student days, there was nothing other than Inderal. And in 1976, then came atenolol. And then we got married to atenolol for almost 3 decades. There was no other beta blocker on the horizon other than atenolol. And it was used for, you name an indication, hypertension, atenolol, supraventricular tachycardia, atenolol, angina, atenolol, perioperative cardiac protection, atenolol, and to some extent even migraine, atenolol. So it was a very widely used beta blocker until it came in a bad limelight. Later I will show you that. And then metoprolol was made in 1969 and bisoprolol and carvedilol 1986 and 1995. However, I must tell you, the journey of bisaprolol has been painfully slow. It was invented in 1976, but got its US FDA approval in 1986 to be commercialized as a medicine to enter the cardiology market and to be marketed. So, why that was so, we will see in a while. Bisaprolol has highest beta-1 selectivity as compared to all other beta blockers like Bisap, betaxolol, metoprolol, atenolol, carvedilol and propranolol are non-cardiac selective. So let's not talk about them. But compared to all others, it has got highest beta-1 selectivity. It is lipid neutral and glucose neutral, contrary to atenolol, with which you are used to for such a long time. Atenolol, as you know, so many trials have shown high chances of new onset of diabetes, high chances of becoming dependent on insulin, and so on. It also causes derangement of lipid profile. The HDL goes low, the LDL goes high with atenolol. That doesn't happen with bisaprolol. And it has got one of the most stable pharmacokinetics. If you see here, plasma elimination life 12 hours, absorption 90%, bioavailability 90%, and protein binding hardly 30%. So if you compare this pharmacokinetics with nebivolol or any other beta blocker, it is one of the most stable pharmacokinetics. Why this is important? Because if you have very high pharmacokinetic variability, the drug levels keep on fluctuating in the plasma, and the drug to peak ratio becomes very low. That means if you take a drug in the morning, the next day morning, before the due dose of the next drug, the effect wears off very badly, very exponentially. So you would not have BP control the next day. You will have early morning surge, something like that. That doesn't happen with bisaprolol. And of course, the side effects like erectile dysfunction are least common with bisaprolol as compared to any other beta blocker that you can think of. So now you will ask me, Dr. Ponde, this beta blocker was so very good, why we are hearing about other beta blockers more than this one so far? And why you are using also other beta blockers more than this one so far? To my humble submission or my humble understanding, there can be only two reasons. VT and Dr. Darshan Jhala is here. They can correct me if I'm wrong. Number one, extremely poor and pathetic marketing by the parent companies. I am very blunt in saying this. And two, and not the least, the cost which was kept initially was so very high. It was 10 times the tablet of atenolol. So obviously, for a cost-sensitive Indian market, the product was simply unaffordable. And these were the two reasons why it didn't penetrate as much as it should have. Now let us see quickly its efficacy in hypertension and coronary artery disease. If you see the beta blocker trials right from MRC, stop 2, happy, MAFI, CAP, ask, happy, UKPDS, ask, invest, and all the way onto ASCOT BPLA. See the beta blockers which are used. Sorry. The beta blockers which are used are all metoprolol, atenolol. That's it. So the world began with atenolol and it stopped at metoprolol. Almost it appeared like that. Every single trial of uncomplicated hypertension used either atenolol or metoprolol. Now, what does this mean? This means that let me not enter the dirty waters, but it also means that the funding of these beta blockers was far much higher for research work. Whereas bisaprolol was made by a company which does not, is a non-profitable pharmaceutical. And therefore, it was never really put into randomized trials. And therefore, there were concerns, as I say them. And had brought thiazide diuretics in the forefront. Lancet meta-analysis was the last nail in the coffin of beta blockers. Second Lancet meta-analysis, in comparison with other antihypertensive drugs, beta blockers are less than optimum with a raised risk of stroke. This one meta-analysis, I remember we reviewed this meta-analysis in our journal club in Hinduja, and everybody said, oh, does it increase the risk of stroke? Then why the hell are we using it? But yes, we were using it. Cochrane meta-analysis, beta blockers inferior to other drugs. Ascot BPLA, calcium channel blocker ACE, amlodipine perindopril combination better than atenolol hydrochlorothiazide combination. CAFE, amlodipine reduced central aortic blood pressure, atenolol did not. So what happened? What actually happened? All these trials compared oranges versus apples. You know, they compared a beta blocker which had multiple side effects, which did not reduce the central aortic pressure, which did not have any effect on vascular endothelium, which was not lipid neutral, which caused increased incidence of new onset of diabetes over years of use, and compared that beta blocker with newer drugs such as amlodipine, perindopril, which is actually a vascular drug. So what result do you expect? You expect this kind of results. And therefore, unfortunately, beta blockers as a family went into the bad limelight. It was actually not all beta blockers. It was only atenolol in the majority of the trials, and in few trials it was metoprolol. And then came the drugs like nebivolol, carvedilol, and bisoprolol. These beta blockers cannot be compared with the previous ones called atenolol and metoprolol because they have got unique pharmacokinetics. They have got vascular endothelial dilating properties. They have got nitric oxide doning properties. They do not cause increased incidence of diabetes. They do not cause lipid abnormalities. They are either lipid neutral or lipid friendly. And they have got excellent trough to peak ratio. Their antiarrhythmic efficacy also is 2 times better than that of atenolol and around 1.5 times better than that of metoprolol. Having said that, look at this study, BMJ Open, that in Indian patients diagnosed with essential hypertension, bisoprolol proved to be safe and very effective. First ever study done in large Indian population. And then came our own Dr. Uday Jadhav, Dr. Tiny Nayars, and Dr. Soumitra Ray's meta-analysis of bisoprolol compared with other beta-1 selective beta blockers in treatment of hypertension. And what was the conclusion? That bisoprolol showed significant reduction in blood pressure, baroreflex sensitivity, and improved HDL cholesterol levels compared to other beta blockers. And there, the journey of newer beta blockers in hypertension began. I remember I had a debate with Uday Jadhav in one of the Brian's conferences here in Taj Lands, and I was talking for beta blockers, and Uday was talking against beta blockers. It was fun, but gone are those days. Now we have better beta blockers, much refined beta blockers. Creative study, bisoprolol showed comparable long-acting effect of BP control, but a more potent long-acting effect of heart rate reduction. All of you must understand, and all of us must understand, that treating hypertension is not treating a magical figure of blood pressure of 140/90 or 160/100 and bring it to 130/80. It's a holistic management of a patient at large. And what does that mean? Control blood pressure, number 1. Control LDL, number 2. Achieve optimal weight, number 3. Number 4, improve vascular health. And last but not the least, control resting heart rate. Our own India heart study, which I will show in a while, conducted in 26 major cities in India, encompassing 18,000 and odd patients, showed that Indian hypertensive patients have higher resting heart rate. You'll ask me, what does high resting heart rate do? High resting heart rate simply reduces your lifespan. That's it. One simple bottom line. You are born with n number of beats written here when you come down. Divide that by the heart rate per minute, gives you your putative life, right? So higher your heart rate, lesser your life. Simple. Exercise blood pressure and heart rate reduction at 24 and 3 hours after taking antihypertensive drug. Comparing bisoprolol versus metoprolol. You see here, bisoprolol has much better control of BP and heart rate at 24 hours as compared to metoprolol. So basically, what does this mean? This molecule is longer acting, it has better therapeutic effect, and therefore it is the most widely used beta blocker in the world in the stable coronary artery subsets. Bisoprolol also improved long-term outcomes in patients with stable angina as compared to nifedipine. Again, this study I will take with a pinch of salt. Again, what are you comparing? Nifedipine versus which causes reflex tachycardia versus a beta blocker. Obviously, beta blocker will do better. Bisoprolol efficacy in acute coronary syndrome. This again, early administration of beta blockers reduces ventricular arrhythmias and sudden cardiac death. If you start beta blockers within 4 hours of admission of a patient to the ICU, you improve his life expectancy, reduce mortality, and reduce ventricular arrhythmias at 7 days, 30 days, 1 year. Not only bisoprolol has shown this. This was shown by atenolol earlier than bisoprolol, but the quantum of reduction was not as impressive as bisoprolol. We all know that in the post-MI period, beta blockers are helpful. We all know that. We all have been using beta blockers as a class 1 recommended drug in patients with acute coronary syndrome. But can I take a vote of hands? How many of you have continued beta blocker beyond 1 year of an MI? 3-4 hands. And how many have given for just first 1 year? Only for 1 year, and beyond 1 year, no beta blocker. All right. So, to evaluate the real world clinical performance of bisoprolol in patients with post-myocardial left ventricular dysfunction, bisoprolol improved ejection fraction significantly at 1 year, along with reduction in resting heart rate and ST segment changes. So, how long beta blockers are to be given? This one meta-analysis says it all. This is line of unity, beta blockers less than 1 year and beta blockers more than 1 year. All cause death, recurrent MI, hospitalization, composite outcome. All better if the beta blockers are continued beyond 1 year. So, beta blockers usually the guidelines recommend are to be given indefinitely if your LVEF is less than 45%, between 45 and normal ejection fraction, possibly indefinitely, only when the ejection fraction is completely normal, which happens only in 5% of ACS. You can afford to discontinue it at 1 year. Bisoprolol in heart failure. Now, again, there are 3 recommended beta blockers in heart failure. Bisoprolol, sustained release metoprolol, and carvedilol. We all know that. Don't talk of any 4th beta blocker in heart failure. How do they compare? These are the studies. CBIS-1, CBIS-2, and CBIS-3 with bisoprolol, MERIT and COMET with metoprolol, US carvedilol, Copernicus with carvedilol, seniors with nebivolol, and BEST with bisoprolol. Negative trials were seniors and BEST. They did not show any benefit. So, for heart failure with reduced ejection fraction, do not use nebivolol. It has not shown any mortality benefit. The first 3 have shown mortality benefit. What is important is resurgence of beta blockers in treatment of heart failure. I remember when I was a medical student, beta blockers were contraindicated in heart failure. And then we took a somersault 180 degrees and started saying these are saviors in heart failure. Can you imagine? Can you believe it? A drug which we are buried alive underground, we took it out for saving our own patients. And that is all science all about. So now the guidelines say when the patient is stabilized, the first 2 drugs with which he goes home is beta blockers and AGL2 inhibitors. This is the algorithm now that we follow, because when the patient is stabilized, the blood pressure is borderline, he is diuresed, so he is mildly hypovolemic, and starting a drug like Arni at that point of time could have hypotension or hyperkalemia or giddiness. So start a drug which doesn't do that. That is bisoprolol and dapagliflozin, or bisoprolol and empagliflozin. These are the two drugs which we need to start. And we need a drug. We need a beta blocker which has shown mortality benefit across all the dosages: 1.25, 2.5, 5 and 10. Bisoprolol is the only drug which has shown mortality benefit at low dose, moderate dose and high dose. Then in heart failure, we have got comorbidities. Every single patient of heart failure has either chronic kidney disease, diabetes, chronic obstructive airway disease, obesity and so on, obstructive sleep apnea, right? Bisoprolol is the only beta blocker which doesn't give damn, I would say, to any associated comorbidity. The mortality benefits are almost consistent. And if you look at the studies, multiple studies showing benefit across all comorbidities. Increasing bisoprolol dose, in fact, lowered the mortality further if you had diabetes as a comorbidity. In all the three beta blocker trials, CBIS-1, CBIS-2 and CBIS-3. Look at, again, didn't we all hear when we were students? Beta blockers are contraindicated in COPD. Am I correct? Now, bisoprolol is the only beta blocker approved by the US FDA for use in COPD patients. So, it doesn't alter FEV1. It doesn't alter the peak expiratory flow rate. In fact, if you look at these several studies, only high-dose metoprolol, high-dose bisoprolol showed significant difference in all-cause mortality in patients with heart failure and COPD combined. So, you have now a beta blocker which you can safely use even when you have a patient with heart failure and COPD. Start with the small dose, 1.25, slowly build it up. The moment you feel a wheeze is appearing, stop at that. That has been my way of using this beta blocker in COPD patients. What about chronic kidney disease? Remember, 1/3 of the patients with heart failure have CKD. And a quarter patients have worsening renal function a week prior to admission. What do you do then? Which beta blocker? Because metoprolol 50% excreted by the kidney. If the patient is on hemodialysis, metoprolol fully dialysable. At the end of dialysis, you will not find metoprolol in the circulation. The beta blocker which is least dialysable is carvedilol, followed by bisoprolol, and all others come later. So people wanted to now check whether in patients with hemodialysis, carvedilol is better or bisoprolol is better, right? Comparing apples versus apples. Now here what happened? Look at the comparative efficacy of bisoprolol and carvedilol among patients. Sorry. Undergoing maintenance hemodialysis. Relative to carvedilol, bisoprolol initiation was associated with lower 2-year risk of death and cardiovascular events, particularly stroke. This is general patients on hemodialysis. What about those with heart failure on hemodialysis? Look at this. Bisoprolol, low risk of all-cause mortality and MACE in heart failure patients undergoing hemodialysis. So my friends, what I've done in the last 15 minutes is showing you huge amount of data on this molecule. But as I say, just knowing data is not enough. You have to translate that into clinical practice. So, what do the guidelines say? The guidelines still say beta blockers in uncomplicated hypertension is fourth step to be used. First step is ACE-ARB. Second step, diuretic. Third step, calcium blocker. And fourth step is beta blockers. But in resistant hypertension, they are step 1. Okay, they are step 1. So here again, in resistant hypertension, you can see bisoprolol or alpha blocker are the drugs of choice. And going further, this is the India heart study, where we studied the middle-aged patients with hypertension in 355 cities in 15 states, 23,000 patients, high resting heart rate. So Indian hypertensive patient is driven sympathetically, meaning we have high sympathetic activity. So don't put beta blockers in step 4 or step 3. They may become step 1 in select patients with uncomplicated hypertension. And I'm sure our brilliant panelists today and moderators will discuss that at the end of this session. So, though the 2020 ISH guidelines also say the same, I would say hypertension with high resting heart rate is one class 1 indication of a beta blocker. And therefore, people have started saying that certain beta blockers may be re-evaluated in the hypertension guidelines. And this paper comes from none other than Goran Karasevic. He is the immediate past president of European Society of Hypertension. And he has written this article saying that some beta blockers need a fresh attention. We have always gone with atenolol and we have condemned, or we have put all other beta blockers in the same basket. We should not do that. So Pearl's bisoprolol, highest beta-1 selectivity, 24-hour action, lowest pharmacokinetic variability, lipid neutral, glucose neutral, lowest incidence of erectile dysfunction, best in class BP control, robust mortality reduction in stable angina, ACS and HEPREP, and all doses in HEPREP reduce mortality, most widely used in the West. And it is now our time to embrace this beta blocker. But the talk is going to be followed by Dr. G.S. Wonder, who is going to enlighten you upon the combination. I will just take half a minute just to tell you that 75% of your hypertensive patients need 2 or more drugs to control blood pressure, not a single drug at all. So combination therapy is a necessity. And all the guidelines, ESC, ESH, and hypertension guidelines, they all strongly recommend combination therapy for hypertension today. So let us have a discussion on the winning combination with Dr. G.S. Wonder. Thank you.
Thanks, Dr. Konde, for that excellent session on bisoprolol. Friends, we purposely kept this to highlight upon you the resurgence of bisoprolol. We have heard many beta blockers in the past. And now we will hear from Dr. Wonder about the combination of bisoprolol with telmisartan. As we said that we have many combinations of telmisartan with other beta blockers. And for the first time, we'll have this. And Dr. Wanda has done the pioneering work of this combination in India. So we are grateful to him, and fortunately we have his presence over here, not physically, but he'll be there virtually. So over to you, Dr. Wanda. Yeah, thank you.
Greetings from Ludhiana. I am Dr. Gurpreet Wanda from Dayanand Medical College and Hospital, and today we have all collected for a very important session in which we will be discussing a new combination of two very well tried and tested drugs, that is a beta blocker and an angiotensin receptor blocker combination in the treatment of hypertension with comorbidities, especially with coronary artery disease. We will look at the benefits, the indications, and the caveats in this combination. We all know hypertension is very common, and as you know, the world population crossed 8 billion, and it is said that the world hypertension population is 1.2 billion. 23% of the population lives in South Asia, to which India belongs and forms 18% of the world population, and 21% lives in East Asia. So when we talk of hypertension in Asians, it virtually actually talks about 45% of the world population. And we all know hypertension in Indians is not the same as hypertension in the other population. Racially, there are significant differences because we have the metabolic syndrome X, and with a prevalence of about 28% in India of hypertension, we know it is responsible for 57% of all strokes and about 1/4 of all coronary artery disease deaths. The very significant global burden of disease study, which was released a couple of years back, shows that in India, CV deaths contribute 50% of all deaths, whereas in the Western population, they contribute 23 to 25% of the total deaths. So what I'm trying to indicate here is hypertension is not only common, it is associated with other risk factors like diabetes, central obesity, insulin resistance syndrome, and a peculiar type of dyslipidemia that we Indians have. And thus hypertension results in much larger morbidity in terms of atherosclerotic end organ disease in the Indian population than in others. We wrote an editorial in the Indian Journal of Medical Research a couple of years back, in which we did discuss about significant differences in terms of hypertension amongst us Indians. The onset is relatively early amongst us. The significant rural-urban divide, which we used to see earlier, there is a convergence because the rural population is now adopting the urban lifestyle. This is well known to all of you actually. As I just said, clustering of multiple risk factors, dyslipidemia, central obesity, higher waist-hip ratio, insulin resistance syndrome, and that results in hypertension causing greater risk of coronary artery disease and cerebral strokes, peripheral vascular disease. There is a significant seasonal variation of blood pressure. We have done some work in this area, and we all know as clinicians that one needs to upregulate therapy in winters and one needs to downregulate therapy in summers when there is excessive sweating. We do know that the average blood pressure in our population is rising, and as a morbidity and as a mortality causing public health issue, hypertension today assumes a very significant actually role it has. And so we have the Indian guidelines, which we brought out first about 22 years back in 2001. And ever since, every 5 to 6 years, we have been updating them. And the latest one are in 2019, and they are due anytime next year now. Well, the definition of hypertension that we have used in our guidelines is similar to the European guidelines. You keep adding 20 to 140 and 10 to 90 to the systolic and diastolic blood pressure, and we move from stage 1 to stage 2 to stage 3. We have emphasized that isolated systolic hypertension is more difficult to treat, and it causes greater end organ damage in hypertension than even the diastolic hypertension, which is something known to everyone. Earlier we used to say we have less data from our country, but today we can proudly say actually there are many studies which have now been published, and this was one of those significant studies which I participated in, published in the Journal of Hypertension, the India Heart Study, which included about 18,000 patients, and we found some very significant things. There is a higher prevalence of white coat hypertension and masked hypertension amongst Indians. So we need to be a little bit more watchful than others. The evening actually blood pressure is higher than the morning blood pressure amongst us. And a very significant actually aspect is elevated resting heart rate. We actually, Indians have somewhat higher heart rates than people of other races, whether it is related to increased intrinsic sympathomymatic activity or it is related to a sedentary lifestyle. But there is data from our country which has been published before also in this paper, which talks about prevalence of sympathetic overactivity in the hypertension population of India. And it does emphasize, as the India Heart Study in which we showed, that the prevalence of increased heart rate amongst us Indians as compared to other races. So besides this one aspect, other aspect which I need to talk about today with you with respect to the product that we are going to discuss is that hypertension is a condition in which we combine multiple drugs in smaller dosages rather than using a single dose. And this has been shown in multiple studies, whether it was the ALLHAT, the HOT, the latest SPRINT trial, the COMPLETE, talk of any. On an average, we need 2 to 3 drugs to be combined for effective control of blood pressure to reach the target heart rate. And it has been shown that a combination is 5 times more effective than doubling the dose of any monotherapy. So unlike epilepsy, the philosophy of treatment here is to have a synergistic effect of multiple antihypertensive agents and to combine blood pressure reducing drugs rather than escalating the dose of a single agent. Also, this concept of single pill combination therapy, which has now come up and has been given by the European guidelines. Actually, the FDC, the fixed dose combinations have been very common in India, and we Indian physicians have been using fixed dose combinations for convenience of compliance, for cost factors. These fixed dose combinations have been used in India for a long time, and you all know we have 2 or 3 drug combinations which are available in India. Well, the journey of antihypertensive drug evolution has been long. Initial ones were diuretics and beta blockers, and the more recent ones were the ACE inhibitors, calcium channel blockers, and the ARBs. And so we have a gamut of drugs from amongst which we can actually combine and tailor make our therapy of hypertension depending upon the comorbidities, the age profile of the patient, and the response, the baseline heart rate. All these factors are actually considered when we are treating our patients of hypertension. Here we are going to talk about a combination of telmisartan and bisoprolol. We know beta blockers were introduced, as I said, they were possibly around the same time as diuretics. Propranolol was the first one, and ever since then we have these newer beta blockers, so to say nebivolol, carvedilol, and bisoprolol, which have beneficial effects in terms of metabolic factors and cardioselectivity also. Well, when we talk of beta blockers, they are not the same, all of them. We have the non-selective and the selective ones. Keep your mind here in bisoprolol, the agent which we are talking of today, but it doesn't have any intrinsic sympathomymatic activity, and it's a selective beta blocker. So there are actually significant differences amongst beta blockers, and suffices to say at this stage that we need to drug, besides the elimination route. Actually, just have a look, 0% actually in liver elimination in metoprolol, and atenolol 100%. So in renal failure, actually we have to be watchful using these drugs. In hepatic failure, we have to be watchful using these drugs, and a very balanced elimination with bisoprolol. So these parameters, actually, no one factor is better than other, but we need to know the drugs and keep in mind that all beta blockers are not the same, and different beta blockers have different levels of selectivity and elimination pathways. And as you can say, bisoprolol and nebivolol are probably the most beta-1 selective agents when you compare them with carvedilol or metoprolol or buxindolol. And so the other effects in patients with chronic obstructive airway disease, those issues will be less with these agents. The third aspect I thought I need to discuss with you before I come to this drug evaluation that we have done is we all know hypertension actually results in left ventricular hypertrophy, which causes diastolic dysfunction and ultimately systolic failure. On the other side, along with other risk factors, it increases the risk of coronary artery disease, which again causes systolic dysfunction. So hypertension, by the time it surfaces to us, has actually some end organ effects in the cardiovascular system. And we know beta blockers have multiple effects in hypertension. They have antiarrhythmic effects. They have a role in coronary artery disease. We know the increased sympathetic activity is countered by beta blocker. They have a great role to play. In fact, beta blockers, the bisoprolol, carvedilol and metoprolol, succinate, these three agents should be given to all patients with heart failure with reduced ejection fraction. So the usage of beta blocker is something like this, depending upon what cardiac effects they have. Because we know beta blockers impact the neurohormonal activation, and through that they reduce arrhythmias, reduce sudden death, affect cardiac remodeling. They are indicated in congestive heart failure. In some of the post-MI trials, they have been shown to reduce actually mortality. And so in post-MI patients, they have been, as I said, used extensively in coronary artery disease. So beta blockers' role in hypertension and its associated cardiovascular effects are significant. Atenolol is the agent amongst the beta blockers which has gone into disrepute after the LIFE trial, in which it was compared with losartan head to head. But right from the beginning, actually, if you look at some of the very initial trials, the MAFI trial, which we know was a primary preventive trial, the beta blockers significantly, as compared to thiazides, reduce total mortality and sudden cardiac death. So people know actually of beta blockers today as not a class effect, but individual beta blockers have to be looked at. In primary prevention, as I just showed you, significant benefits as compared to diuretics. Secondary prevention, we all know actually beta blockers have a role in post-MI patients, significant 42% actually relative reduction, and heart failure you all use it in. So beta blockers have significant, as I said, beneficial effects in hypertension with comorbidities. The other molecule we know actually, the angiotensin receptor blockers or ACE inhibitors, they affect the efferent arteriole tone, thus they reduce the intraglomerular pressure. And so there is initially, although there is a decrease in eGFR, but then it stabilizes and thus it reduces albuminuria. There is significant renal protection, and we know diabetic patients with microalbuminuria, the ARBs are even more effective than ACE inhibitors, although there is not much difference between the two. But certainly we like to use actually the RAS blockers, whether it is ACE inhibitors or ARBs, in patients with diabetes and hypertension with microalbuminuria. Telmisartan is an agent amongst the angiotensin receptor blockers. As you know, they affect the AT1 receptor, and thus they reduce the sympathetic nerve stimulation, reduce vasoconstriction. And we know actually angiotensin 2 is the most potent vasoconstrictor, and they have cardiac as well as metabolic factors. It provides effective, telmisartan has some pleiotropic effects also, and it provides effective reduction in blood pressure. It's a once a day drug as compared to losartan, which is a twice a day. We know telmisartan causes significant and persistent reduction in blood pressure, and so it is used once in a day. Many landmark trials, you know, the most significant one, the On Target, Transcend, the Detail and Amadio, all these trials have evaluated hypertension, telmisartan in hypertension, although telmisartan is not used as an agent in LV dysfunction, but as an antihypertensive agent, probably telmisartan is the most used angiotensin receptor blocker, and this actually reflects in the 2019 Indian guidelines on hypertension as well. The American guidelines, if you see, look at How they actually talk of in stable coronary artery disease, the blood pressure goal is yes, less than 130/80. In fact, they have given a blanket target of 130/80, although we in the Indian guidelines have a range in which we want our patients to be managed, because we know blood pressure cannot be static at one level. But coming back to our topic today, first line agents are beta blockers and ACE inhibitors or ARBs in patients with stable coronary artery disease, and these are the agents which you can use as for further control. Patients, even the European guidelines, if you look at actually ACE inhibitors or ARBs plus beta blockers or CCBs, this is what you will do in patients with hypertension with coronary artery disease. So there is a definitive role this combination has as a first line agents. And so also when atrial fibrillation, actually the commonest cause of atrial fibrillation in adults is hypertension, and when it occurs, even for prevention, actually the RAS blockers have significant role. Beta blockers will control the heart rate when it occurs. So these agents are coming back to the combination actually. So for these very reasons actually, in this first Indian clinical trial, we evaluated telmisartan 40 milligrams plus bisoprolol 5 milligrams and compared it with a fixed dose combination of telmisartan and metoprolol succinate. It's a randomized, double-blind, parallel group, multicentric phase 3 clinical study, and it compares the efficacy, looks at the safety and the tolerability of this fixed dose combination tablet of, as I just mentioned, in patients with stage 1 and stage 2 hypertension, and a lot of them have cardiac comorbidity along with it. Actually, the cardiac actually target organ effect in these people. So as I said, study design is multicentric, randomized, double-blind, parallel group. We evaluated more than 250 patients, and they were enrolled from 10 centers across India. The study centers were actually 10 study centers were involved. I was there from the Anand Medical College and Hospital, Ludhiana, Punjab. Dr. Bhimram was there from Patna, Bihar. Dr. Satyendra Kumar Sonkar from Lucknow, Uttar Pradesh. Dr. C.M. Manjunath from Bangalore. Dr. Padmanabh Kamath from Mangalore, Karnataka. Srinivasa Murthy from Bangalore, Karnataka. Bala Murugan from Coimbatore, Tamil Nadu. Narasingha Rao from Srikakulam. Debabrata Rao from Kolkata, West Bengal, and Prajapati Bachubhai from Ahmedabad, Gujarat. So we had 10 centers actually in which these patients were recruited, and as you can see, this was from across the country. And let us look at the results. The change in blood pressure from baseline to 12 weeks. The baseline blood pressure in group A, which consisted of telmisartan and metoprolol, was 154. And the baseline blood pressure in group B systolic was 155. So similar blood pressures, significant reduction in group A, which was telmisartan plus metoprolol, and in group B, which was telmisartan plus bisoprolol. And similar response of about 14 to 15 millimeters of mercury in the diastolic blood pressure. So on an average, 25 millimeter fall in systolic and about 15 millimeters of mercury fall in diastolic. The group B, which consisted of telmisartan and bisoprolol, caused greater reduction in systolic and the diastolic blood pressure as compared to group A, which was a combination of metoprolol and telmisartan. So this is actually the summary of the results that we have, and this is what we got in terms of comparison of the two groups. So the mean difference in systolic, actually sitting systolic blood pressure from baseline to 12 weeks was better in telmisartan and bisoprolol group when compared to telmisartan plus metoprolol, and this difference was 3.5 millimeter and was statistically significant. So as you can see, actually there is an initial significant fall in blood pressure which continues over a period of time, and whether it is group A or B. So this gives you a trend in terms of how blood pressure comes down in these people, and the mean change from baseline to week 12 in group A and B was significant, and you can see the difference was also significant. This gives the trends of diastolic blood pressure from baseline to the end of study, and as we saw in the systolic blood pressure, the diastolic blood pressure also actually fell initially and then continued to fall over a period of time, whether it was group A or whether it was group B, and the mean change in diastolic blood pressure from baseline to week 12 in group A and B was significant. If we look at the younger population of 18 to 50 years, Group A and Group B, there was a significant fall, and we know that young age hypertension is high renin hypertension, and the younger patients actually respond better to the elderly patients. So this is a special actually group. Although we did find a significant actually response in the elderly also, and the response with combination of telmisartan and bisoprolol was better than with the combination of telmisartan and metoprolol. The tolerability assessment was actually excellent response with both the agents, and there were no actually withdrawals because of any side effects. So as we have shown, this combination is equally almost actually very effective. The combination of telmisartan and bisoprolol a little bit more effective than that with metoprolol, and tolerability issues are very little with both these. So as I said, there are no major adverse events that were reported. 7% subjects reported mild to moderate adverse events, and none of the adverse event actually required discontinuation of treatment of the drug, and most events resolved completely. We did actually look at the vital signs, the ECG, echocardiogram. So these patients were very closely monitored throughout the study period. I would like to conclude here, friends, by saying that the results of this randomized double-blind parallel group multicentric phase 3 clinical study established that the fixed dose combination of telmisartan and bisoprolol in group B was not only non-inferior to the fixed dose combination of telmisartan and metoprolol succinate, but it also proved to be superior in terms of marginally greater reduction in systolic as well as diastolic blood pressure, and more so in the younger population, where it is, I'm sure, going to be used pretty often. And so we have a combination now of telmisartan and bisoprolol, which is going to be available to us, which has been shown to be safe and effective in this randomized controlled trial. Thank you. Greetings from Ludhiana. I am Dr. Gurpreet Wander from Dayanand Medical College and Hospital, and today we have all collected for
Hello, doctor.
Thank you, sir. Thanks, a wonderful thanks to Dr. Ponde and Dr. Wander for their wonderful deliberations. I think these two talks really put bisoprolol way ahead of rest of the beta blockers thing. I think the shift in the market is really happening from metoprolol and other beta blockers to bisoprolol. So probably these two talks really consolidated the thought process. Going forward, like I told you initially, that this program has been live streamed across 30 centers in the country. Now I'd request my colleagues across the country to disconnect and start off with your panel discussions locally. So the Mumbai program would continue from here on. Now I request Dr. Sadanand Shetty, who has joined us, to take over the session and carry on with the panel discussions and the question and answer session. In the meantime, when they're joining on the stage, I'll leave everybody with a small 2-minute AV about the product. Thank you very much.
The ASC-ASH guidelines and the ASH-ISH recommend the use of ARB and beta blocker in the management of hypertension and cardiac comorbidities. Now, experience the combined benefits of the most preferred beta blocker in the most trusted ARB in a single pill. For the first time in India, post-clinical trials, DCGI approves Micro Labs to manufacture and market the new fixed-dose combination of bisoprolol and telmisartan. Micro Labs proudly announces the launch of Biso-T, the first brand with the combination of bisoprolol and telmisartan. Dr. Micro Labs has conducted the first Indian multicentric clinical trial on the combination in 10 premium institutions of the country, such as Sri Jaydevar Institute, Bengaluru, DMC, Ludhiana, R.N. Tagore Institute, Kolkata, KMC Hospital, Mangalore, among others. The results showed that not only the BP reduction was better with Biso-T as compared to the metoprolol and telmisartan. Biso-T was also well tolerated in all the subjects. What's more, doctor, the first Indian bioequivalence study conducted by Micro Labs showed Biso-T was bioequivalent to bisoprolol 5 mg and telmisartan 40 mg administered separately. The novel combination of bisoprolol and telmisartan ensures effective BP control, dosing convenience, favorable pharmacokinetic parameters, and is highly beneficial in hypertension with comorbidities. Bisoti brings the benefits of superior beta blocker bisoprolol, whose efficacy has been proven in landmark trials like BRIGHT, Creative, Bisocad, and CBs. Doctor, please prescribe India's first Bisoti. Bisoti works across the cardiovascular continuum. Bisoti provides the benefits of bisoprolol and telmisartan in a single pill. Bisoti once daily has shown significant BP reduction and was well tolerated in Indian hypertensives. Bisoti provides flexibility to shift existing patients to the FDC to reduce the pill burden and improve compliance. Doctor, requesting your valuable prescriptions for Bisoti. Works across the cardiovascular disease continuum.
I think at the outset, I would like to thank Microlab Education Academy and our own academy. Myself and Dr. Vetisha founded the CCA, which is an educative, of course, Ponde, Darshan Jala, they all know about it. And I'm extremely sorry, straight away coming from the lab, when you want to do some program in time, you are stuck actually. And at one time I thought, possibly I may not make it, In fact, we have been considering this program for a couple of months. And Sirish, has planned quite a, good CME on this topic. In fact, this is the first in the world actually. We must first of all compliment actually Sirish. Microlab has put, of course, Ponde rightly. So many times I heard about bisoprolol. I don't think we have any person better than Ponde to talk about bisoprolol. I think it's most favorite and most of our favorite molecule. Unfortunately, in our country, it is in less use, but now in combo, this preparation is available. And that's very important for all of us. Now, we have a panel discussion. I would request my friend Dr. Vetisha first to come on the stage, Dr. Ponde and Dr. Darshan Jadaya. Sirish, Dr. Bhaskar, oh, sorry, Bhaskar, come here. I didn't see you. So initially, I'm going to initiate few questions what Sirish want. I would say Dr. Sirish want because he knows so much about this combination than us. I would put few of the questions, my questions what I want to clarify, and then we would take questions from all of you. And if anyone want to make comment, you are welcome. And with this brief introduction, once again, welcome you for this panel discussion on behalf of our academy and Micro Lab Education Academy. The first question, this combination of beta blocker and ARB, telmisartan, how do you find it? Then the second is whether bisoprolol along with metoprolol, telmisartan, or your nebiolol, telmisartan, all these combinations existing. As we all know, bisoprolol and telmisartan combination is the first in use. And most of the guideline, barring the ESC guideline, which is the only one which says beta blocker can be used in hypertension, unlike all the other guidelines. Indian guideline also has put beta blocker for young hypertension, particularly people who are very anxious, hyperdynamic, etc. So how do you find a brief remark from each one of you? Maybe I will start with Ponde first, beta blocker and ARB combination, telmisartan. And then same continuation, how you put biso plus T. Let us talk today only biso T, otherwise Sirish won't be happy. No bisoprolol and telmisartan, only biso T. So biso T versus nebiolol, telmisartan, metoprolol, telmisartan combo.
I think here the difference is the type of beta blocker you are using. You are using a beta blocker which is most proven in terms of its efficacy in heart failure, its safety in patients with COPD, its safety in patients on hemodialysis, and its robust mortality benefits across all ranges of ejection fraction in patients with hepatitis. Also in uncomplicated hypertension, this combination is very good for maintaining resting heart rate at low level, curbing down the exercise-induced increments in heart rate, and giving a robust 24/7 BP control. So this is how I will put it for a BSOT as a combination molecule. Even for an uncomplicated hypertension with high resting heart rate, this could be the first molecule of choice. Even if you put guidelines, even if you look at the guidelines, you would not hesitate using this molecule. Thank you.
Your comment?
Yeah, so let me add to what first Shekhar said. Is the least amongst the beta blockers the least to cause sexual impotency, right? So besides giving low numbers of diabetic population or any effect on the lipid profile, the advantages of bisoprolol over other beta blockers. The other thing is, yes, we have RAS inhibitor along with the beta blocker now in this. And if you had that population, young population with increased sympathetic activity, this would be the combination. And otherwise, in our practice, where most of our patients are like post-ACS or with LV dysfunction, bisoprolol telmisartan is the most common combination which we use. And I would say here that even in your practice, if you have not done a 2D echo and starting a combination, then I think bisoprolol telmisartan would be the safest. Because otherwise you have to see whether the 2D echo, what does it show, whether the function is normal or not, or whether there is dysfunction. So if you have not done a 2D echo and you want to start a beta blocker, bisoprolol, you want to start for hypertension, bisoprolol plus telmisartan, because that's the most commonest ARB which will be used. Secondly, the dosage pattern. 40 milligram telmisartan is the most common. So depending upon the heart rate which you want, 2.5 or 5, or the blood pressure which you want. So that's the adjustment. Plus, if you think that the blood pressure is still not controlled and the heart rate is still not controlled, you can use the same combination twice a day. Because otherwise, as we know, telmisartan can go up to 80 and bisoprolol can go up to 10 milligrams. So both ways, it would be a win-win combination.
Bhaskar, your comment. And adding to all, Indian hypertension, as shown in Indian Heart Study, primarily the resting heart rate is much higher than across the world. And therefore, obviously, it makes sense in using this drug. Because normally we say that the first combination is calcium blocker and RAS inhibitors or ARBs. But the question which comes up in our population, if you look at across the world, beta blocker is very low down in the card. But because Indian hypertension, the resting heart rate is much, much higher. Therefore, these drugs also come parallel and maybe little ahead in all young hypertensive or ND hypertensive with a resting heart rate being on the higher side. So that is what we have to remember. Because the question which will always come up is, if you go by guidelines, it is calcium channel blocker and RAS inhibitors ARB. Then why this comes faster or ahead? In our population, as I told you, resting heart rate, as I told you, would be one of the major reasons why these drugs come parallel or maybe ahead.
So logically speaking, if you have to think the two drivers which drive hypertension are RAS system and the sympathetic system. So it would make sense to combine, use drugs which would tackle both, because hypertension has multiple pathophysiologic mechanisms. So then why is it that so far we were not considering this? The reason is said by Dr. Ponde that wrong beta blockers will be used. And that is why they got a bad name as a class. So we have to rethink now and come back that now we have a beta blocker which has proven benefits, which is long acting. The half-life matches with the other combination which goes by. It tackles both the main responsible systems. And we have a data proven beta blocker which has benefits in multiple subsets of comorbidity individuals. So I think it's a good combination. We have to rethink our thing. Just let's not go by whatever the guidelines say. We use our own judgment and use it properly.
Darshan, yeah, just to add to this, and please don't expect any trial on bisoprolol further because it is off patent. So no company is going to fund that and give you some head-to-head comparison. Whatever data we have, I think we should go. Plus this combination, you all know that combination, fixed dose combination therapy, both in diabetes and hypertension started with India. The guidelines came later. So similarly, I think in future, though some of the guidelines are already mentioning bisoprolol and some, especially when hypertension is associated with left ventricular hypertrophy, bisoprolol will be much more choice rather than any other.
Yeah, just to conclude upon all this, the first thing is that, as Darshan said, sympathetic overactivity and the RAS. And among the best sympathetic overactivity, beta blocker, bisoprolol, for the reasons what Ponde mentioned. In heart failure also, the drug among the beta blocker first comes bisoprolol. Because many times in heart failure, we have a BP to start with low. But the falling effect, BP effect of the bisoprolol is less than the other beta blocker. That's one important advantage. Then, COPD, people who got a hyperactive airway disease, bisoprolol is preferred because the selectivity, that beta 1 selectivity is very good. So it doesn't affect much of the lung symptoms. And if you see among the sartans, the telmisartan is the most sold and the most popular and most used the sartan among us. If you see all those earlier generation, then even olmesartan came and then the azilsartan. Still the market services, telmisartan is the most common. So today we have a combo of two, blunting one sympathetic, because as Dr. Bhaskar said, we are all, most of us were part of that study, India study, where our resting heart rate average is around 80 plus. And that is why we want to blend the heart rate also, whether heart failure or in hypertension. In fact, today, heart rate is a risk factor for most of the cardiovascular disease. If you keep heart rate between 60 to 70, even heart failure, even for that matter, hypertension with multiple comorbidities is better. So I personally feel, we didn't have, unfortunately, we were not using beta for hypertension because we fall to Western guidelines. So don't fall to Western guidelines. Dr. Darshan rightly mentioned, beta blocker in young hypertension is a big role. In fact, beta blocker, telmisartan is the most common or most sought after combo of the antihypertensive young people. But now with the bisoprolol, we are little, better off. And even in patients with heart failure, we can't use RNA for some reason. Cost effectiveness, some people cannot cannot buy or cannot take at all. Adherence is the problem. Then again, bisoprolol and telmisartan will go, combo will be better. So I think that part is quite clear. Anything you want to add, or we'll go to the next one? Yeah. Anyone want to make a comment till I ask further questions? Anyone? Yeah. Nalini Kumar. Yeah. One minute, we'll give the mic, first Narendra Kumar, then we'll come to the Rane, just take care of mic there. Yeah.
Yes, BSOP has come with a combination. Here the telmisartan is used. Now other metoprolols are also used with the either telmisartan or olmesartan. What is the reason that few brands are coming with telmisartan, few brands are with olmesartan? Which is better, telmisartan or olmesartan? Can you comment on that?
No, between, I don't know, but my personal thing, again, I would, at one time, when it came, probably olmesartan we were dividing equally and all. Later, some of the antioxidant, anti-inflammatory property. Then one trial came, roadmap, where, there is a little more adverse event and all. And generally, if you see, even in a diabetic, PPAR gamma effect is supposed to be better with telmisartan. And most of the time, as we said, diabetes, hypertension is almost 50% comorbidities. So, this way, the combination came. But there are still, as you said rightly, olmesartan with metoprolol, But in fact, the combination of metoprolol, olmesartan is a small dose of chlorthalidone also. In fact, that way we must complement our pharma, Indian pharma, all combo available very easily. Yeah. So I would say my practical thing, I would little put edge over telmisartan over olmesartan. And azilsartan, I don't know, some other it didn't, at least in our pen. I will have a quick comment from panelists.
Plus, I think telmisartan has much more robust data in terms of studies and trials versus olmesartan. Olmesartan has more study on the kidney protection rather than any cardiac, just like we have on target and other trials on telmisartan. So I think if you have to go by whatever scientific evidence is considered amongst these sartans, I think telmisartan would score over others.
Yeah.
Yeah. Telmisartan is known to inhibit matrix metallopeptidase 9 enzyme on macrophages, expression of that enzyme, which stabilizes an atheromatous plaque. Now, that means that while it will reduce the blood pressure, it may increase your liability of a stroke. Secondly, angiotensin 2 accumulation causes myocardial fibrosis. Now, while telmisartan blocks angiotensin 2, it does not stop the increase of production of angiotensin 2, which the body will reflexly produce because the blood pressure is not being modulated. It has been controlled by telmisartan. Third thing, evening rise of blood pressure. Does that mean we give blood pressure medicines in the evening?
No, I think, in India, actually, in our own study, in fact, most of us were in the study group. And finding what was found in that study, evening BP is more in our patient, and the resting heart rate average at 82 or so. So that is one thing, So there again, timing of the drug, whether morning or night for blood pressure management, is a topic by itself, but we still stick to morning. Only one Spanish study came where they given in the night, but that is still not substantiated. Most of the international experts still say you stick to the morning. Yeah. Metoprolol inhibitor is a standard for most of the ARBs and all. And what we talk about when we are using ACE inhibitor, ACE escape, then angiotensin escape, then when you talk about MRA blocker, the aldosterone escape. These are all, I think, today's time is not greatly clinically relevant according to me. So I want to ask a question and Bhaskar about this.
About the reflex increase in the angiotensin 2 levels, that is because the AT1 receptor is blocked. There is an explanation for that, why that does not produce bad effects. The thing is, the excess angiotensin 2 is converted to angiotensin 1,7 by ACE2, not ACE1, ACE2. Angiotensin 1,7 is a beneficial molecule. And it has all the reverse effects of angiotensin.
Yeah, probably
and that is how excess angiotensin 2 is beneficial that way.
Yeah, and that's why in the studies of telmisartan, we didn't have these side effects. You understand? So these were not shown. Yes.
And also, when you talk about azilsartan, what he mentioned that these all effects are little blunted, but in practice, I don't know about azilsartan and about in practice. Anyway, let us come to the topic.
And one question, one short about what he said about do we have to give an evening dose of antihypertensive? You see the pharmacokinetics of bisoprolol and telmisartan, see the half-life, they match to it. And that's why if you see the next day morning heart rate is still controlled if you give this combination rather than if you use other combinations.
That is why most of the antihypertensive combo are long activity. So morning or evening again, that type of thing doesn't come much. So you have got double combination, triple combination, ARB, beta blocker, CCB is there, ARB, beta blocker, chlorthalidone is there. But here we are talking about a drug which is for hypertension, maybe for heart failure, where people cannot give, take ARNI. We talk about ARNI only in heart failure today, but ARNI cannot be for everyone. But maybe from January, once it goes into off patent, ARNI may probably replace the other drug. So till then, I think, probably the combo, this is superior, I would say.
Sir, nebivolol is also supposed to be very cardioselective. Dr. Ponde, can you please comment whether nebivolol versus bisoprolol, would it be more selective and really does it make a difference? If I have a patient who's on nebivolol with telmisartan, should I actually have reasons to convert it into bisoprolol?
Yeah, okay. I'll give you a few points to ponder upon. You can check the literature yourself and double check them. First and foremost, that nebivolol has a little lesser beta-1 selectivity as compared to bisoprolol. That is the first point. Second point, exactly the same reason what you said. A senior's trial was conducted in patients, elderly patients with heart failure. And the way we expected benefits, we had benefits with bisoprolol, carvedilol, and metoprolol sustained release in reduction of mortality in a very robust manner, 34% relative risk reduction in mortality. We expected that with nebivolol. Nebivolol reduced heart failure hospitalizations in that trial, but was no significant effect on mortality. After that, no mortality trial has ever been conducted with nebivolol in heart failure with reduced ejection fraction. That is the second thing. Third, all these, there are certain drugs, which, how would I say, they look good on paper, but have not replicated themselves in clinical practice or trials. Similar things, unfortunately, have happened with nebivolol. So, in fact, there was a US FDA black box warning on unsubstantiated claims with nebivolol to be condemned in US. This was in 2014, again replicated in 2016. So please remember that it looks fairly good, beta-1 selective and etc. And it has got nitric oxide diuretic properties and has been promoted at one time with peripheral vascular disease as well. But somehow it does not show its benefits in the real world.
Actually, very appropriate. Actually, in fact, Indian hypertensive guideline mentioned nebivolol already. I don't think we should totally disregard that product actually because of its NO ability, nitric oxide donor and all. And but see, I will tell you how my perception about this combo. Initially, we were giving metoprolol and telmisartan commonly. Moment the nebivolol telmisartan came, little switch to telmisartan nebivolol. But now since BSO-T is there, we'll switch to BSO-T. Because there's nothing against it as compared to this combo. If you go by strictly guideline, Indian hypertensive guideline mention nebivolol. I think some Western guideline also, Canadian guideline or some guideline also has given nebivolol, because of selectivity. I agree with you. In fact, selectivity, in fact, theoretically more than even bisoprolol also. But in clinical practice, it is not been, substantiated. So I personally feel, it is not that today BSO-T is coming, so let us jump to that we had like typical in American till yesterday we were doing all wrong things. Not like that. But what better we have got molecule in all the respect, that's what we are discussing. So my prescription pattern now may change to BSO-T because of these, advantages. And the cost thing. Bhaskar, any comment?
Yes, I mean, repeating what Dr. Vitisha said, if you want to start a drug without doing a 2D echo, we are not really sure about the LV function. And we know that in patients with poor LV function, nebivolol doesn't work well, on the contrary, it was negative. Therefore, blindly, if you want to use probably bisoprolol with telmisartan, will be more better off than nebivolol.
Yeah, particularly for heart failure, you talk about this combo will be superior. Metoprolol with telmisartan is okay, but nebivolol is not proven, except for one small study, senior study. Not like bisoprolol, your studies, SIB study and all those studies. So, dedicated studies, bisoprolol, metoprolol, carvedilol. That way, carvedilol also for hypertension recommended, but I don't know how often you are using like that. So basically today, I think, the BSO-T combo 2.5 and 40, important 2.5, 40 because sometimes we go telmisartan to 80 also. 2.5 morning, 2.5, 40 in the night. So Vitisha mentioned morning and night, suppose in case if you have to step up the dosage. So I think, personally speaking, looks very novel and quite synergism between the two and blunting both sympathetic and the. These are the two fundamental systems in cardiovascular medicine. Anything you talk about blunting heart rate, blunting sympathetic to the balance, blunting RAS to the whatever optimum you want. That's the key. Whether you talk about diabetes, hypertension, coronary artery disease, etc. Heart rate is very, very important risk factor. In fact, it's called one of the important risk factor, risk marker, for all this.
Sir, with the kind attention of metoprolol, Bisot, and the combination now which you talked about is in relation with hypertension and the cardio and the atherosclerosis, lipid, etc., and the benefits of the same. I would like to draw an attention hypertension with.
Can you stand up? Because I can't see you only.
So hypertension and the relation with the kidney. So the pressure, the renal pressure. So now how do we look about this component with that?
Cardiorenal you're talking about?
I'm talking about hypertension with renal.
Yeah, I think Shekhar covered that topic very well. He showed one slide, but I would ask him to again please highlight. The question is hypertension with renal failure. What combination would be better? Bisoprolol, telmisartan, or metoprolol, telmisartan? That was, and I think you showed in the slide.
Yeah. Out of all the beta blockers, the highest dialyzable beta blockers are atenolol and metoprolol. So if the patient is on metoprolol, to put it very simply, you are given a morning dose, and afternoon he undergoes dialysis. By evening there will be no metoprolol in his system at all. If you give bisoprolol, at least 70% of the bisoprolol will be still in the system, 30% will be washed off with dialysis. With carvedilol, it will be almost 90% carvedilol still in the system. So we all thought that in dialyzed patients, carvedilol will do better than bisoprolol. But what happened in clinical trials, that bisoprolol had higher effect on mortality and higher effect on reduction of heart failure hospitalizations and higher effect in 3-point reduction of MACE in both patients with preserved ejection fraction and reduced ejection fraction. And this was possibly they feel it is because the carvedilol being having an alpha blocking effect as well, that worked adversely for mortality reduction in heart failure. That was the possible hypothesis of. But this is what the answer, if this answers your question, ma'am.
Yeah, go ahead. So when he says effect, he is saying benefit. Yeah. Sushil, you want to say something? Come.
Yeah, I want to, the question which he asked, whether these drugs or which is the best drug to prevent the hypertensive nephropathy.
Oh, is that? No, I thought she said metoprolol. Anyway, but this also we can answer.
Well, I think all the three beta blockers, carvedilol, bisoprolol, and nebivolol, I think all these three are head-to-head in comparison. And somewhere bisoprolol is better in heart failure, while the nebivolol is better in the sexual dysfunction. While carvedilol is equally good in heart failure patients. And as he said, carvedilol and bisoprolol is non-dialyzable. So that is in comparison to metoprolol. But what is in comparison to nebivolol? Whether nebivolol is equally dialyzable or not. And what angiotensin 2 is converted into 1,7 is more with the azilsartan rather than telmisartan. So azilsartan is said to be much more potent than telmisartan. No doubt about the use of telmisartan is much higher than azilsartan, but efficacy-wise, azilsartan is said to be more effective than telmisartan. And third thing, evening dose of the hypertensive. So many people prefer the evening dose of the antihypertensive. So you reduce the morning surge of the hypertension as well as heart rate as well. So evening doses are equally good and is to be followed. Thank you.
Yeah. So again, as far as azilsartan is considered, there is no doubt it has got long acting 36 hours. But again, the problem is that we don't have sufficient outcome data on azilsartan or olmesartan. That is one. So yes, if you compare the long-acting, telmisartan is not as long-acting as azilsartan, but we use telmisartan more because we have robust data on that. As far as your other evening dose, yes. So we answered partly that bisoprolol has never been tested for that in terms of a combination with any sartan as far as the morning surge is considered. But I think he showed in his slide that if you use bisoprolol, the morning heart rate control is better with bisoprolol as compared to metoprolol, or I am talking of metoprolol sustained release. Even metoprolol sustained release doesn't have that morning reduction of heart rate as compared to bisoprolol. So that is one. And rest you asked about nebivolol. I'll ask him about nebivolol, whether dialysable or not.
No, actually, there is no data available on dialysability of nebivolol. There is only one small Egyptian study, not very highly reliable, of 300 or 3 to 400 patients, which said that the 70% of the nebivolol is completely dialysable. So only 30% remains in the system. But the kind of large data we have with bisoprolol and carvedilol and metoprolol, we don't have about nebivolol.
Sushil, you know, the timing I addressed earlier also, that has not been substantiated now. When you are using long-acting single, double or triple combo, morning dose, all international experts. Azilsartan also many session we had. Michael Weber is one who is very, very populistic about this particular product, but didn't come up that in India. In fact, what you said is that he is one that, all those things, we have discussed about it in the past. And unfortunately, azilsartan market survey, if you see in India, it is not that. We don't have too many combination of azilsartan, amlodipine, or cilnidipine and things like that. See, today is an era of combo. Let us accept that, because of the adherence of the therapy there. And cardio protection, renal protection, the beta blocker, it is not, we are not talking about renal protection is in the ARB and things, ACE inhibitor, like that, not beta blocker. Optimum control of blood pressure is what we want that. Dialysable liver disease or renal disease, which beta blocker is that? Like metoprolol is basically metoprolol the liver, so renal disease probably you can give up like that, things like that. And the other thing, I don't know whether she was meaning after starting sartan ACE inhibitor in RAS blocker, there is a fall in, the GFR, creatine goes down by at least 20-25%. So we have to be a little cautious in the beginning. But once you are stable beyond 4 to 6 weeks, it protects the kidney. GFR in fact improves like that. So I think today we are talking about a single drug, double drug in a hypertension. We give only in when we require two doses of, like for example, some you are given in the morning, some you want to give in the evening to control the blood pressure. In a diabetic or a CKD, autonomic dysfunction, where the night dip is not good. In fact, they all have elevated night pressure. Nocturnal dipping is a little bit blunted. That's because of the I10 RAS activity. So if you give small dose of diuretic, again giving in the evening night is again a problem, which is again most of the time our combo in hypertension consists small dose of clotharol, because we are very, very salt sensitive. India is very, very salt sensitive here. Any other comments? Sir? Just 1 minute, yeah. Yes, yeah.
As you all know that diabetes is strongly related to CAD as well as hypertension, and India is hub of diabetes. And there are equal number of pre-diabetics in our society, which are detected later on. Many times we see that coronary event occurs first, and after 10 years the person is detected to be diabetic. So this combination, I feel that it's a combination which can tackle knowingly or unknowingly, because of its PPAR gamma activity, we can tackle with the pre-diabetes patient also. So what's your say about that?
Yeah, you want to make comment? PPAR gamma, is supposed to be among the sartan. I agree with you, the maximum with telmisartan. In the beginning, telmisartan people used to say only with PPAR gamma with telmisartan. And then when they reviewed the literature, some, report is the other. But I agree with you. PPAR gamma is one property we take positive for Ponde. What are your comments, VT? Anything you want to say that? That is an additive. I agree with you. In fact, these are the reason why, telmisartan is a preferred one. Yeah. And then the trial, what you said, the first one is the on target. Yeah. In fact, that on target, the trial data, I think, when it was presented, we were, in that group to interact with the PI of the on-target trial. And that, has continued. And as Dr. Vitisha mentioned, a lot of studies favoring this particular molecule, So among the sartan, whatever it is, I think the telmisartan is the sartan, yeah. And that pre-diabetic, pre-PPAR gamma effect is a positive, I agree with, yeah. Any you want to make comment about that, or is okay? Yeah, next, yeah.
My two opinions are there. As Dr. Vitisha said, blindly if you want to start the beta blocker, bisoprolol is the good drug. But in my opinion, by history, if you feel there's some impaired left ventricular function, then I will prefer to start Tramadol rather than a bisoprolol or Nebilol. Number one. Number two, my comment is this, that if the patient is having an anxiety element or he is very stress-induced person, then I would like to do combination of beta blockers in the morning time. If the anxiety element is not there, stress is not there, then I would prefer to give beta blockers in night time to prevent the circadian movements. Any comment?
No comments, I don't know. Personally, for heart failure and all, carvedal or some of the other, this alpha blocking effect, vasodilating one side, like this ACE inhibitor versus ARB, that alpha effect in beta blocker does have a lot of the negativity, particularly the lung and other things are concerned. And it's not a selective one. Like it's a non-selective beta blocker, so therefore preferred one is a selective. And now we have got bisoprolol, we have got metoprolol. So we can use that. I don't know, that's my personal opinion, that's my personal practice. I'm more committed to that. Carvedilol is like a non-selective, not a truly long-acting. That's why it's got CR preparations, unlike metoprolol and bisoprolol. So these are the limitations. Yeah. Yeah, Namit. Yeah.
Dr. Vitisha, you have been emphasizing that you can give it twice a day. Don't you think there would be an accumulation of the drug and cause serious side effects, like bringing down the heart rate in the night to below 50?
2.5 Navneet, 2.5 40 BD is saying, if it is required.
No, he said 240 plus 2.5 or 5.
Correct. That is
what my suggestion is.
So the heart rate is not concerned. The idea
just one
is
second. Listen to me. See, what my point is that why not individualize the doses of both the drugs separately and then combine it? What's the problem in that?
Not at all. There is no problem. If you want to give two separate drugs, you have more flexibility dosage.
See, that's what my...
Navneet, what you're saying is absolutely true. There's a basic in medicine. Start small dose and build up one, then combo. But there's also indication to use combo upfront. There are indication also. If you have to get the systolic less than 20, diastolic less than 10, upfront 2 drug you can give. There's a guideline we have got.
But I'm talking about the accumulation of the drugs. These are long-acting drugs and there is a possibility of accumulation of the drugs.
I'll just give you a corollary, anti-diabetic, we know glimepiride sometimes we use 2 times, 3 times also. Don't you think chlorpropamide was used 2-3 times? It is not a short acting. For a control, we do use, So these are little, not exactly pharmaco principle wise, but we still use, Long acting medicine, 24-hour effective, as you said, why to use 2 times? That question always is there in my mind, In that case, I use probably triple combo or maybe one other drug, Maybe aldosterone blocker for a resistant hypertension like that. Yeah. You wanted to, sorry? Call it off? Yeah. I did a watch. Sirish, you want to make some comments? Anyone for 10 o'clock? 10 o'clock. Right. I think we can maybe during our meal time and water time, So Sirish has done excellent arrangement, and I must once again confess, I think Sirish has done, more than 1,000 people all, pan India. And this CME like this, positively, I never heard it like this, at one given time.
Hybrid.
Hybrid, that also.
We have done plenty of virtual.
Plenty of virtual. We have done plenty, Some of our virtual we are attending up to 4,000, 5,000 people. But a hybrid like this, attending more than 1,000 is a great thing. So thank you once again thank you all the panelists for.
Pleasure, sir. The last count, what I got about 10 minutes back was 1,840 people physically across 30 locations. I think that was a wonderful thing. Well, thank you very much, sir, for your wonderful deliberations. I think thanks to the audience. You have been lovely audience. I think the questions that came out were very practical and probably that would help you to take your day-to-day practice into the next level. Thank you very much. And I request my colleague Chetan Rane to hand over a small memento as a token of respect from our side to the panel members. Dr. Jhala, thank you very much, sir. Dr. Shah, thank you very much. Thanks for your time and presence. And Dr. Sadanand Shetty, thanks a lot for all your cooperation for the programs and getting this program on. Dr. Shah. And Dr. Ponde, ever thankful to you, sir. Thank you very much, and request all of you to join us for dinner.